Okay, can everybody see this? Yes, perfect. I love the head nods. So welcome everybody. Today I'm going to be talking about managing sexualized behaviors in children. Part of what I plan to go over, I'm not going to go really into the psychopathology of it. I'm going to go more into defining the sexualized behavior, looking at healthy sexualized behavior versus problematic. And so really determining that. I think so many times we have families that come in our office and talk about sexualized behaviors and or when we're in their homes talking about sexualized behaviors. And so just defining that as a provider, like where it's healthy and where it can become problematic and what we should be looking at. Common sexual behaviors, when to have concern, and then some of the treatment and some techniques and some resources that I have used. I'll share with you guys. And please feel free to stop me at any point if you guys have questions or if I'm going too fast or if I said something you don't understand, please feel free. So what are sexualized behaviors? When we're talking about sexualized behaviors, we're talking about any type of touching or masturbating in the genital areas that could be in private or in public, right? Those are still sexualized behaviors. Again, some healthy. So we're going to go over what's healthy and what's unhealthy. Looking at touching a peer's genital areas, or new siblings. Sometimes we have very curious little ones when they get a new sibling, kind of looking in those areas. Sometimes in foster families, when a new sibling comes in, if we have a child who is struggling with any type of compulsive sexual behavior, many times we'll have kids who kind of might groom their the younger siblings or siblings coming in. And so that's something to look out for too, but some of it is healthy. Exposing themselves, so showing themselves to peers, to public, to teachers. So that's also sexualized behaviors. Sometimes, again, kids who have compulsive sexual behavior issues, you'll see standing or sitting too close, and it's all about intention, and we'll talk a little bit about that too towards the end. But sometimes that the frottage is part of compulsive sexual behaviors, and frottage is rubbing against or sitting next to somebody. And so if you think about it, sometimes it's just the sense of rubbing against or the sense of the power knowing they can rub against. Sometimes it's the sensation, right? And so if you sit, like I'm thinking, because I have like tank top on today, if I sat next to somebody, I could feel their arms, right? And so sometimes that's a sensation too. And so again, it's all about the intent. Trying to see peers naked or adults. So we're just going to talk about masturbation for a minute, because I always seem to have parents who ask me a lot of questions about masturbation. And so this seems to be, and we're going to talk about masturbation in a lot of the upcoming slides. So we're just going to touch on this really quick. And what I really do is I explore families' beliefs on masturbation, because it'll help in your behavioral plan and how to help reduce any type of sexualized behaviors that families might be coming to you for if it's unhealthy or problematic, right? So really taking that into consideration. Sometimes, especially families who have, and we'll talk about the plans, but sometimes, like if I have kids who are in foster care who have had trauma and have been sexually stimulated, they're going to continue to seek that. Any kid can continue to seek that, right? It can happen to any kid. So kids 4 and under have spontaneous erections all the time, like little boys have spontaneous erections. And sometimes those erections can become stimulated. They can't climax, but they can still become stimulated, right? And so, and sometimes they'll continue to seek that. If something feels good to you, you're going to keep seeking that out. And so a lot of the times that's where we'll see this start to occur. So masturbation commonly occurs when kids are sleepy, bored, watching TV. That's a lot of the times where you see the hands go in the pants. And so really just redirecting that under stress. Stress is a big one too. Masturbation actually releases a relaxing hormone. And so a lot of the times that's where it can help with stressful situations. It also releases dopamine, so it makes them happy. And so if you have kids, and this is where the love lines can be crossed, right? That's a little bit of the psychopathology is, early on, if kids are abused, if they're sexually abused and they experience that, then their love lines can be crossed, right? And so their neurons in their brains can be crossed because they're getting excitement and happiness from this interaction that occurs in an unhealthy way. And so they continue to seek that out. So that's kind of where that pattern comes from. But for the most, what I talk to parents about is ignoring during sleep and nap times if they can. Again, exploring their beliefs, because some parents don't feel like you should ignore that. And so we talk about ways to manage that in a behavioral way. However, I also talk with them about repercussions from being very rigid around that, because it could lead into some more defiant behaviors. But we talk about distract and discipline during other times. So looking at ways to distract and discipline other times. So looking at common behaviors for children 4 and under, these kids are exploring, right? So they're exploring their private areas, they're exploring their bodies, they're pulling, yanking, touching. So it happens all the time. A lot of the times they'll rub against objects, they'll rub their hands in those areas. And again, if they were stimulated in any way, I mean, it can happen to anything, like a clitoris can be stimulated by a bicycle, sitting on a lap, right? Like, so, the penis can be rubbed in a certain way where it would stimulate it. And so sometimes that stimulation just occurs and they'll continue to seek it. And so a lot of the times when parents discipline and distract them from that, then it goes away, right? And so it's kind of like anything else that would stimulate a kid too. And so toys stimulate kids in the same way, right? It's just not, it's a dopamine release. And so they're going to seek that out. Showing privates to others is completely appropriate at this age. This is what they do. They want to make sure that others have the same things that they have. They talk about it. They think it's funny. A lot of the times you'll see kids 4 and under wanting to be naked, right? How many times do you have parents that say, I just can't keep clothes on my kid? Is that normal? Yes, it is. When they're 4 and under, totally normal. Kids attempting to see other kids, adults and kids getting dressed, right? They just want to peek and see. Adults have different biology as kids do. So they naturally want to see that and see what's going on there. They talk about their own bodily functions and others' bodily functions, and they think it's funny. So they talk about that. You'll see a lot of kids too, 4 and under, seeking comfort from their moms and sticking their hands down their shirts, right? I don't know if any of you have had kids and had your kids stick their hand down their shirt. It's just a comforting thing, right? And sometimes you'll see kids just place their hand there, right on their mom's breast, and just let it sit there. So sometimes it can be a comforting piece, and that's completely healthy. So when you're looking at 4 to 6, same thing, they're purposely touching in their genital areas. Sometimes they're doing it in the presence of others. And so this is where you see parents become a little more strict and kind of redirect. And so then it'll become private in the next age range, but this is where they sometimes do it in front of others, attempting to see other people when naked again. This is where you start to see some of the mimicking behaviors, right? So kissing, holding hands, kids will act this out with one another. They'll do it through play, they'll play doctor, they'll play house. They'll play with their dolls, right? They'll lay their dolls either like next to each other, on top of each other. So this is where they're kind of exploring that, and that's totally appropriate. And then the 7 to 12, masturbation becomes more private, right? So they're looking to be private, and overall, this is where they start to learn and explore who they're liking, the interest in their peers, and so they're definitely becoming more private. They're playing different games like boyfriend, girl, let's play boyfriend, girlfriend, like the younger, the 7, 8 age, truth or dare. As they get a little bit older, right, they start to explore some of that, attempting to see people undress. This is where you start to see kids too start to take notice in like people getting naked on movies and in games, and so they're wanting to see a little bit more of that, and they go towards more of the sexually explicit media, and yeah. Then so those are common behaviors, and so a lot of the times we get kind of lost in like what's common, what's developmentally appropriate, what's not. This is a great chart that I've used several times, well, all the time. I use it from the American Academy of Pediatrics. And it really helps you distinguish like what's common, what's normal behaviors. And then you'll see the orange and the pinkish purple, right? So those show, and they really demonstrate the uncommon behaviors. Start to talk about what is becoming a concern. And so some concerns, asking peers or adults to engage in specific sexual acts, right? So that's definitely a concern. Many of the times you'll see kids inserting different objects into their genitals, or talk about being asked to insert different objects, or asking others to insert different objects. And so you definitely want to be concerned at that point. Talking about intercourse or engaging in intercourse, touching animal genitals, or even penetration to animal genitals. So that's definitely a concern. Sexual behaviors that are often disruptive to others. So, you know, acting out sexually. So, I mean, I think of a kid that I had that would masturbate on the arms of the couches and the arms of the chairs, and while she was watching TV. And so like, this was clearly disruptive to everybody else in the household. And so that's a concern. I also had another little girl that would sit on her foot in class and masturbate that way. And that became disruptive to the entire class, right? And so it's very disruptive to others. And if behaviors are persistent and with direction, they're not responding a lot of the times. And it's a concern if kids then become angry too. So if they're not responding to that redirection or to the discipline that can be incorporated with engaging in sexual behaviors in public areas, then it's a major concern. And so other major concerns that are rarely normal are any sexual behaviors that are involving children who are 4 or more years apart, right? And so kids who are much older, kind of grooming and perpetrating kids that are younger, adults grooming children as well. So just being aware of that. A variety of sexual behaviors that are displayed on a daily basis. Sexual behavior that could result in emotional and physical pain. So this would be the coercion or forcefully forcing themselves onto others. So becoming physical, or, you know, creating that emotional distress. Sexual behaviors that are associated with physically aggressive behaviors. That's a major concern. This could be physically forcing themselves, or this could be physical aggression that creates arousal, stimulation, and continuing to look for that. I had a boy who was 13 years old, and he actually hurt himself pretty significantly because his way to climax was to physically beat his penis, like punch it. And so that became very harmful to him, but that was the only way he was stimulated. So, and it came from abuse. And so naturally he turned into just looking for that physical aggression to climax, and he ended up really hurting himself. So that's very uncommon though. So that I have never seen a case like that actually, besides that one. So that's really uncommon. Sexual behaviors that involve coercion, behaviors that are persistent. Again, if the kid becomes angry when parents trying to distract or redirect. So this is a great chart. This is super helpful. I just wanted to go over those. I hate reading slides, but I just wanted to go over that for you guys so that you knew exactly what those were. And, you know, sometimes you think to yourself, well, like, does this fall in that category? Does it not? And so any questions about that, I'm happy to help if I can. So healthy sexual behavior, again, this is all about where it's coming from, right? Healthy sexual behavior comes from a place of curiosity, kind of trying to see, understand, learn, Behavior that's spontaneous and mutual, same age range, involves positive affect, behavior that is responsive to redirection, and involves children of similar age or development. And so this is a big piece too, because sometimes we come across situations where we have, if you look at the uncommon sexual behavior, it's that 4-year age gap. But sometimes we have kids that have intellectual disabilities that sometimes don't really understand the difference, or they might have sexual behavior on a lower age range. So chronologically, they're older, but developmentally, they're still functioning lower. And so they display some of that. And so sometimes you definitely have to take that into consideration when looking at that and managing some healthy sexual behavior and low frequency of it. Problematic sexual behavior, behaviors that seem to be a preoccupation, really take over, right? It becomes an obsessive thought, and that can become problematic. Engaging in advanced sexual behavior knowledge. So these are the kids that you are talking about sex and they're younger, and you're like, whoa, like that's pretty advanced for you, right? And knowledge of it. Behaviors that seem targeted towards a specific population. Again, emotionally distressing, anything that's coerced. Inappropriate age. So these are some of the same things. Inappropriate age, the frequency, it interferes with their development or functioning. So influencing factors on some of those problematic sexual behaviors are their situation, right? What's going on with them? Have they been involved in a trauma? Was there abuse or neglect? Their environment, what type of environment were they exposed to? What did they see? Are there any disabilities that could be there? So disabilities, are there, do they have ADHD? Are there any intellectual disabilities? Do they have any obsessive thinking? A lot of the times that can be very stimulating. And so kids who are very hyperactive at times could have some hypersexuality, and so obsessing thoughts as well. And so many of the times they can get caught up in that. And actually, a lot of the times, and especially if we look at some of those common factors of the age ranges, 7 to 12, kids are starting to look at more media. And I'm finding that sometimes my kids with really who are very hyperactive in that age range, like 8 and 9-year-olds, a lot of the times they're looking for that. And so they'll find those games that pop up, or those things that pop up on social media that, are inappropriate, and you click on it and it shows you a bunch of things, and they might do it by accident once or twice, but then they become stimulated by it, so they continue to seek that out, right? It's like this hyper arousal, and so they continue to seek that out, and so it can lead into an addiction with porn, and so and some hypersexuality. And so I've seen it done with a couple cases, and it's pretty interesting. Dysfunction or stressful home. A lot of the times, what's interesting that I found is a lot of the times when I worked with adolescent sex offender on a residential unit, sex offenders, there was a good bit who had completely dysfunctional homes, right? And the more I'm reading, the more treatment goes towards the pattern of interactions within the homes, and the level of dysfunction, and how that can reduce some problematic sexual behavior. But a lot of the times in the residential, when I worked there, a lot of the times what we would see is that there was just really poor boundaries within the homes. And so not that they were offended, not that they were taking advantage of themselves, but that there were really poor boundaries. And so poor boundaries meaning they shared rooms with one another, their siblings, and they would get dressed in front of one another. That maybe an adult would walk around naked right after they got out of the shower. They would just walk around the house naked. Sometimes I had families that would come in. I remember one patient in particular, one of the factors for him was he slept with his parents until he was about 13, right? And his parents would have sexual intercourse in the same bed as him, thinking he was asleep at times. And they totally thought nothing of this, right? And it was like something that happened. You know, mom said she slept with her parents and her parents did that too. She knew they did. I had one patient that she heard sexual intercourse from her parents like almost every night because the walls were so thin, and so it led to some curiosity, to sexual arousal, to some hypersexual arousal. And so a lot of the times it was just poor boundaries, and not creating some of those boundaries. So it was pretty interesting. So again, when is it a concern? When it's done in front of others, if you suspect that they were taught about it, or if a child's feeling unhappy. Many of the times kids who are having problems with sexual compulsive behaviors, they're pretty unhappy. Kids who are being offended themselves are pretty unhappy. And so just looking at that, that seems to be a common factor in a lot of the research, is the level of depression. When is it a problem? Act out, in the occurrences increase. They're not able to be redirected. Again, nothing is helpful for them. And if it's associated with physical aggression, this becomes a major problem. So the most effective treatment is individual therapy, group therapy, family therapy, and residential. When you're looking at individual therapy and family therapy and group therapy, when you're looking at all three of those, CBT and TF-CBT seem to be the most effective and very beneficial. But again, in reading a lot of the literature now, they're looking at early on parent-child interaction, and naturally attachment and protective factors come into play, as well as their development, where they're at. And they talk a lot about, when they talk about the development, they talk about just the poor boundaries and the interactions and how that can impact. And so having family therapy can be very beneficial. Providing some of that psychoeducation to families is super beneficial. Residential, if it's to that level, usually kids in residential are court ordered to be there. And so that's not usually something where somebody places. Quite honestly, I've worked with offenders, and I've worked with victims, and so I've worked with a little bit of both. And a lot of people have asked me why I work with offenders. Like when I did sex offender group, and I worked in a prison, a maximum sentence penitentiary, and I worked with sex offender groups, and a lot of people were like, I don't know how you could do that, work with kids. But it kind of gives you a balance, right? Like, when you work with victims and you hear about them being offended or perpetrated on, it's so easy to think of somebody who treated them so wrong and did this wrong thing to them. But when you work with offenders themselves, you can kind of understand it a little bit more. So I think it helps me treat better to know both sides. So I think it's really helpful. Plus, we come across a lot of young adolescent offenders and child offenders. And so I think it's good to take into consideration some of the influences that could have factored in with them. And it's not always just sexual abuse that is being a repetition. Sometimes it's a pattern of interaction that we have to intervene and assist with. And so it's really important. So that family therapy component is really important. Group therapy is important. Group therapy provides that accountability and holds them accountable. To be honest, other than kids, like when I've treated offenders who are adults, if they've not been court ordered to do it, I've not had really success rate on bringing them back. They don't tend to follow through. Kids do, I think, because families really, really put into that, engage in. And a lot of your initial approach is going to be behavioral, because if you can change some of those behavioral patterns of interaction early on, then it can help redirect some of those thoughts. The biggest problem you're going to come into is if there's a sustained thought disorder, then you're going to have some lifelong treatment. But a lot of the times, it's more of a behavior disorder early on. If it does become the thought disorder, it is the thought disorder, then it is necessary for ongoing treatment, and sometimes residential. So so just with the treatment, the behavioral techniques, psychotherapy, we talked about that, cognitive behavioral impairment child involvement. Some of the psychoeducation you want to provide, talking to kids, and it's amazing because sometimes we think that they assume that they should know this, right? How their behaviors impact other children and other families. So we want to do some of that empathy building. We want to make sure they understand how their actions are impacting others. Giving specific recommendations for schools to help schools out and for other children. I had one little girl, she couldn't go to the bathroom alone because she would climb and look for others inappropriately. And so she had to have an aide, and after the age, she had a peer that was able, so she got to the age where, you know, when she was 9, she didn't want the aide to go to the bathroom with her. She wanted a peer, but the peer had to stand at the door with the door open, right? The peer was not permitted. And so then the teacher could watch from the hallway, ensuring that both children were safe, but helping to incorporate some independence and trust in that little girl. And so that was super beneficial, and it was really important. But we needed to ensure safety first, and we always had to ensure safety first. I think her mom had a hard time with that because you know, these things were happening and they weren't following through with safety plans, and then it would continue to happen, and mom would just be completely, you know, the adopted mom would be so very devastated. And we talked about, this is something that's going to have to continue to happen, right? It's like an addiction, and that stimulation sometimes. And she was a victim of awful abuse, and she was probably the worst sexual abuse case that I've ever had to deal with. But she's worked really hard and has gotten to a place where it's very rare that those incidents occur now. Specific behavior management strategies to reinforce the appropriate behavior and to reduce the negative behavior. And so again, a lot of the times this is around masturbation, and we talk about ways to reduce it or to allow privacy areas. A lot of parents don't want to do that. And quite honestly, I've had maybe a handful of parents that don't want to do that. And half of them have come back to me after they said, absolutely not. We talked about ways to absolutely not. And then they came back and said, okay, well, what if we let it? And once they allowed that to happen in a private area, it actually reduced the behaviors altogether. So I thought that was interesting. You always want to do safety planning. And so really this is part of the psychoeducation and educating families, but also providing safety plan. You want to make sure and ensure that there's close supervision, right? And sometimes parents get frustrated with this piece because it's so much more work on them, but we want to ensure the child's safety, and we want to ensure other kids' safety, other individuals' safety. You know, if their child has been sexually abused, if you have a child that's been sexually abused or is acting out sexually or has compulsive sexual behaviors, there's a good chance they can act that out on others, right? We saw some of the problematic behaviors being behaviors towards peers, towards siblings, and so naturally they could act out towards others. And so you just want to ensure safety altogether. So close supervision is beneficial, not allowing them to play in bedrooms, not allowing them to have doors shut, door shut. Yeah, I said that right. Doors shut. So making sure that they're on the appropriate media, limiting their time on the media. So limiting their exposure to media. Anything nude needs to be gone. Making sure there's separate rooms, separate beds. They're not in the same room and sleeping with other children. Clear rules of what happens if they display any type of compulsive sexual behaviors, where they should, where it's appropriate, where it's not. So really clear rules, privacy rules. So making sure that not only they remain private, but they understand others' privacy rules, right? Like when the doors are shut, that means that your sibling does not want you to enter the room. You can't enter the room. When the bathroom's door shut, you have to knock on the bathroom door, right? So clear privacy rules, personal care rules in private, right? Like, so if you do have to masturbate, this is where you masturbate. And if it becomes a problem, then we talk about it. I've had parents that have set up that rule, and then their kids are in their room all day and they're like, I don't know if they're masturbating or if they're not, and I don't know what to do. And so we talk about ways to kind of manage that and to just check in, right? and if it is going on, again, if the frequency is increasing, then it's still problematic. And so we talk about ways to kind of manage that. But, overall, in general, and modesty, just making sure that parents are modest in front of their children. I had one kid that had some sexual compulsive behaviors, and their parents were very, I don't know, it's not modest. They were all over each other all the time, and inappropriately, grinding at times. And so they didn't understand the impact that this had on their child. So it was having those discussions. I mean, they're super awkward conversations, and they can be very difficult, but really important. I mean, sometimes it's amazing that people don't realize the impact on their kids and other people within the community. And so same thing with parents who just don't want to address it. And grandparents. I mean, I've had grandparents that come in and they're like, they know some of these things are going on, but they don't ever talk to them about it because they just don't know how, and they don't know what to say. And then so when they say these behaviors, and then they get real red and embarrassed themselves, and they don't know how to handle it. And so we talk about ways to kind of manage that. But it's important. And sometimes that's all they need, is they need us there to help facilitate a conversation too, to help with these clear rules and clear boundaries. And sometimes, I mean, if you think about it, if you had to go talk to somebody about that, being modest, and you had to go talk to somebody about that, like in public, like imagine, standing in a grandstand and telling a whole audience about your sexual behaviors, like totally embarrassing, right? And so you don't think about things. You can't think about how to manage it. You can't think about how it should be appropriate. And so you almost lose that, right? And so when there's an emotional attachment to it, it's really hard for parents to think through of how to manage it. And so sometimes they just need us to help facilitate that and manage it. And so safety planning can be very beneficial for that. So these are some resources that I use. I mean, you guys who have seen this before or seen me speak before, I always talk about the National Child Traumatic Stress Network. Super great resource for this as well. Trainings on the therapy and how to manage it. And, but these are also some other very helpful resources that I help educate kids, review with kids. I help give to parents so that they can educate. The Safe Touching Coloring book is a great way. It kind of makes me cringe when parents come in and they're like, good touch and bad touch. And I'm like, no, don't call it that. So, because what happens is, if you have kids who have had, abusive situations and have experienced trauma themselves, many of the times when we talk about bad touch, like some kids, so I had one little girl when she was 4, and she grew up, she was sexually abused early on, and one way that she showed affection to her foster father was she would grab his inner thigh, right? And so he would be totally uncomfortable with this, and that's how she thought. And again, going back to the intention, so when we asked her what she was doing, she's like, I love him, I want to show him I love him, right? And so he's like, I don't want her to show me she loves me that way in session. And so what we actually, what we ended up doing was I had to separate and work with him on how to manage his emotions when we're having these conversations, because she's 4. And so she, in her mind, this is how she's showing you affection. This is how she's showing you love. Super uncomfortable for you. So let's talk about that. And so we manage with him so that he can have that conversation with her without shaming her. It's really important that she didn't feel shame at that time, because this is how she was showed affection. This is how she was showed attention. And so she thought she was doing the right thing. So if you go to telling kids that they're bad for doing this, then they're going to start thinking that they're bad people. They're not bad people, right? They just kind of learned this inappropriate interaction early on. And so we almost have to retrain that brain and kind of show them appropriate interactions. And so really helping parents and kids understand that. That's why family therapy is super beneficial, especially for kids 7 and under, because working with them separately, and many of the times you are preparing those adults how to manage some of these difficult conversations and how to handle it. I had one family where they were super upset because they adopted this little girl who again came from a very abusive home, and she would be triggered just by them kissing. So like they couldn't kiss. Talk about modesty. Like they couldn't kiss in front of her for about a year until we worked through some things, and then they were able to slowly kiss. And so we actually did a little bit of exposure therapy with her, and she did fabulous with it. It took her a while. It took her a year, but she did really great with it. But anyway, so this coloring book is a great way to talk about safe touching, not good touching, not bad touching, but safe touching. And it goes through and talks about safe touching being high fives, hugs, right? Handshakes, and those are safe touching. And so unsafe touching is a hit, a punch, anything that's unwanted. And so it also talks about in the bathing suit areas. So touches in the bathing suit areas. The great part about this book, and this is an educational piece that I think kids should definitely have, is when you're having this discussion, is that you also talk about who can touch in those areas, when they can touch in those areas, and if someone touches in those areas that are not supposed to, who can you tell? And so it really prepares them for that situation. And this is a great coloring book to do with the entire family, to do with kids individually sometimes. Really just depends on their situation. The other book is a very touching book. And I used to read this. I have to tell you guys, I used to read this book to both of my kids growing up, just so that they were aware. And I think because working with offenders, you become like more vigilant of that. And so, and I was working on that. But one of the things, I would read this book, and my husband picked it up one time. He said, "What are you reading to the kids?" I said, "Well, I'm just preparing them to know what to do if anything ever happened to them." So he's like, "I cannot believe this." So, but what made him freak out a little bit is there's like cartoon naked people in here of all different shapes and sizes. And it talks about how everybody's differently shaped and sized. And it talks about saying the words out loud that everybody gets embarrassed about, like penis, vagina. And so it really talks about that. And then it talks about what to do if there was an unsafe touch. And so it's really kind of a funny way to kind of get kids starting to feel comfortable about talking about it and expressing to the adults in their lives who are safe, that need to know if anything were to happen. So that's all I have. Those are my references. Any questions?
I just wanted to say thank you so much. That was a really great presentation. You included like really good resources and personal, stories that you have had as an example. And I think many people that don't do this type of therapy, or I'm not a parent, but my parents were hilarious about it. Just talking about the sex, where my dad, I think when I turned 13, he was just like, "Go to your mom if you have any questions about this, or this." And my mom's Spanish, and she'd be like, "Oh, Lisa, why are you asking?" So it's really funny. And I think that it's also really important. Yeah, you can say somebody's going to abuse is just really sad, or knowing what's normal or not. So yeah, you did a really great job. So I just wanted to say
thank you. Yeah, it has a huge impact on kids, and kids are watching. When you're a parent, kids are watching you. Kids are watching for your response and your interaction. They want to know what they feel safe coming to you with. And it's so funny. I'll tell you guys this personal story too. So my son, when he was like 7, he was 7, and he said something like at my mom's house, he said like whore or something. And I was like, "What?" And then when we got in the car, I was like, "Do you know what a whore is?" And he said, "Yeah, a whore is a woman who beats her kids." And I was like, "No, that's not what a whore is." And so I told him what a whore was. And then we're in the car, right? And so then I go into the sex talk with everything. And he literally put himself against the window. He goes, "Mom, why are you doing this? You are so not normal. Nobody else's mom will talk to them about this stuff. Why are you doing this?" I said, "Well, because you're asked, you need to know because you're talking about these words."
Yes, absolutely. Yeah. So I think that's very important, and people could bring this to their practices and their life as parents. So thank you. And does anybody have any comments or questions?
No, I second that, because I think sometimes being in our fields, like with my nephew, my brother, and I mean, they've been together since they've been 18. They're not really married, but we pretty much call her his wife. But they called me one time and was like, "Hey, we're noticing, he's taking long showers and, you know, he's in his bedroom a lot. Like, can you tell us what is normal versus not normal? And I was like, you're his parents, like, you know, and they didn't want to have the talk. Like, they wanted me, they're like, well, you're studying psychology. You had the talk, weren't you? And I was like, well, you're the parent. But so, yeah, it is. I think it is a hard topic for parents to talk about, but it's definitely needed.
Yeah.
Or, you know, I think the better you are off. So education.
Yeah.
I
I
have
agree.
a question.
Yeah.
Amanda, can you speak to, sometimes I see families with kind of that tween age and they have advanced knowledge and experience of sexual interactions with peers, adults. It's not appropriate, but they've been aroused, so they want it. And kind of the grown up or the caregiver, their messaging is, you're too young, wait till you're 16. Or wait until you're like, there's this magical age where they can flip a switch and then they can just let loose all their sexual fantasies, whatever. So what kind of language, do you have any tips on language or to try to change that messaging a little bit?
To like to the parent. So I would definitely be doing some family work, right? And changing that pattern of interaction. So one of the treatments is that pattern of interaction between the two. And so working with that parent on, you know, where this belief is coming from. And so I think exploring that, like, where is this belief coming from and exactly how that message might be interpreted. And so you might want to work on enactment between the two. So taking the two and understanding both of their beliefs, like, you know, for the transition age child, like, what is going on with you? Like, where did you learn some of this? When did you start exploring some of this? Build that relationship so they feel comfortable talking to you about that. Build a relationship with the parent and then bringing them together. Is that helpful? Okay.
Yeah, it is. So kind of encouraging the caregiver to treat it more as a conversation rather than a like, hey, this is the magical age where everything is now fine.
Absolutely. Absolutely. Well, thank you
so much. What was that? Thank you, guys. I think I heard an echo, but all right. If there aren't any other questions, Alicia, you go ahead again with your announcement for the group since we've had some others join since. Thank you.
Sure, thanks. So maybe a repeat for those who are on, but we just wanted to circle back. We wanted to kind of put a call out for volunteers. So we have a new program starting, and for those who aren't familiar, I'm Alicia Heil. I'm coordinator of the Safe and Effective Management of Pain program at Rational Drug Therapy. We have Angie Wochuk here. She's the director of Rational Drug, and then our assistant director, Chris Hale, is here as well. And we have our intern, Jessica. But we have a new program. So if you weren't familiar with our Safe and Effective Management of Pain program, we created guidelines that we formed a statewide panel of experts to put the best practices of pain management out there. There was a lot of academic detailing and focus on education of providers across the state. And then we also at Rational Drug have a drug utilization program looking at high-dose opioid regimens. So we have been asked to look at some data regarding stimulant use in children, and some of the counties, there are kind of these hotspots where there's really high levels of prescribing. And so through a Title V grant, we've been asked to kind of mimic the approach with our Safe and Effective Management of Pain guidelines and do create an ADHD guideline with regards to appropriate evaluation, diagnosis, treatment, promotion of some of those other non-pharmacological therapies when appropriate. But we are looking for experts on the panel at this point, and then we would head a academic detailing focus later on after those guidelines were created. So that is pretty much it. We're definitely open to any questions at this point. It's a very early stage in the project where we're, like I said, just creating the panel, and then we would focus on creation of those guidelines. But our email addresses are in the chat as well if it's something that you would like to participate in, or if you knew anyone else interested in participating.
Well, I probably would like to participate. I think I joined before I got your email. Could you put it in the chat again for me?
Absolutely. I can actually reach out to you. I have been in contact with Christina Duncan, and she recommended to reach out to you as well for the panel. So
Okay,
I'll just reach
yes,
out to
I
you
would be happy
that
to
works.
be involved. I'm probably one of the higher dose prescribers at sometimes too, but I think it's a very important thing, and I would love to be involved.
Awesome. Well, we appreciate that. And I don't think you've shown up on our list, so
I'll put
we definitely have.
I'll put my email in the chat, and you can just send me whatever you need.
Sounds great. Thank you.
Great, thank you so much, Dr. Sagar. And again, yeah, the emails are listed there, and you can reach out to Mitra or myself too if you'd like more information or to get in contact with them. Thank you again, Alicia.
Thank you.
All right, so my only announcement before I launch the poll is our next session will take place on August 18th, and Emily Finnemore will be discussing the hidden superpowers of lived experiences. So that'll be very interesting, I am sure. Thank you so much for everyone that joined, and just give me a moment while I pop this up.